Hello everyone, my name is Dr. Raymond Benza. I am the principal investigator for the Cereno CS1 trial.
What are the pathogenetic features of pulmonary arterial hypertension, PAH, and why is it so difficult to treat?
Yeah, PAH is a very terrible condition. It is really one that we match with some of the most deadly cancers that we treat in medicine, in that it has a 2.5-year survival rate without therapy. And as I mentioned, its pathophysiology is very similar to cancer in that the cells within the blood vessels of the lungs grow in an unchecked manner. And when this happens, the blood vessels occlude. And that's a very dangerous situation because the right heart, which is responsible for pumping blood through those vessels, is a very flimsily made part of the heart. It's very thin-walled, it's not very muscular. And when it sees this pressure coming back from the lung due to these occluded vessels, the right heart dilates and fails. And when that happens, people will die from the disease. So this is really a disease of heart failure, despite the primary signs and symptoms coming from the lung.
Is there a typical PAH patient?
This is a disease of women. There is a 5-to-1 predilection for women in most cases in patients who have pulmonary arterial hypertension, particularly the idiopathic form of pulmonary arterial hypertension, which likely has some genetic basis to it. There are many other forms of pulmonary arterial hypertension that we can see in patients who were infected with the human immunodeficiency virus, those who have connective tissue diseases, particularly scleroderma, those born with congenital heart disease who actually have holes in their hearts, like atrial septal defects or ventricular septal defects, and a whole variety of other conditions. Pulmonary arterial hypertension is obviously a rare disease, but pulmonary hypertension itself, which is the huge umbrella under which pulmonary arterial hypertension sits, is a very common disease because it's associated with very clinically common conditions like COPD, interstitial lung disease, and even congestive heart failure. So it's very important for clinicians to keep their eye out for this because it is a very common disease. And when they find someone with pulmonary hypertension, they really have to do their due diligence to actually subcategorize them as pulmonary arterial hypertension because the mortality and morbidity between the various forms of pulmonary hypertension is very different, and PAH is one of the most deadliest forms.
What are the unique challenges of managing patients with PAH? How has the management of PAH shifted in recent years?
The most difficult problem we have with pulmonary arterial hypertension is that many of the symptoms are common with other common diseases, particularly respiratory diseases, asthma or COPD. And so many people don't actually dig deeper to determine whether they actually have elevated pressures in their chest. And that means that diagnosis is often delayed by several years. And that is really critical time where we could be managing those patients and preventing their right hearts from failing, which, as I mentioned earlier, is really the key thing that determines prognosis in this disease. And so over the last 2 decades, we've really tried to make an honest educational effort in the community to let physicians and clinicians and allied health professionals know to look for pulmonary hypertension, to know the risk factors for pulmonary hypertension. And when they see those risk factors, they need to grab an echocardiogram to see if the pressure in the lung is high, and then we can go down the diagnostic path there. Now, when someone is diagnosed with pulmonary arterial hypertension, one of the most important things we need to do is determine their risk of dying or their risk of having morbid events like being hospitalized. And that has been a real significant improvement in our management skills over the last decade because now we have several new risk calculators that we can use to accurately determine the patient prognosis and thereby allowing us to more intelligently use our medications to make these people feel better, function better, and live longer.
What are the limitations of current therapies?
So our current therapies right now really focus on maximizing the diameter of the blood vessels in the lungs, the pulmonary arteries, where the disease actually takes place. And that has provided improvements in people's functional capacity, how far they can walk, their quality of life. And we believe that it has improved mortality. The life expectancy for a treated patient with pulmonary arterial hypertension has improved from 2.5 years, as I mentioned earlier, to around 7 years now. And we take a lot of pride in that. But if you think about it, 7 years of additional life for a young woman of childbearing age, that's not a lot of runway we're giving them. And so our therapies have failed to really remodel the disease, to really hold it in its track and regress it. And that is where the pace of new therapies like CS1 are coming in that really focus on the arteries, remodeling them, restructuring them, trying to get them back to a normal state so normal flow can go through these arteries and relieve the pressure on the right heart.
What are the prospects for patients with PAH currently receiving standard of care?
We feel that current therapy has improved life expectancy, but as I mentioned, it's only a small runway. We went from 2.5 years to 7 years, and again, for a disease that affects mostly middle-aged women, that's not a lot of runway. And so we want better than that. We want newer therapies that can extend that life expectancy even more, and most importantly, we want people to stop having morbid events. Our drugs have done a great job helping people live longer and function better, but they're still being hospitalized. They're still having morbid events. They're using technology that interferes with their lifestyle when they have to walk around with a pump that continuously gives them medications. So there are a lot of improvements that we're seeking in the community, and again, brings us back to the need for therapeutics that we can match with our new scoring systems that can really help remodel the vessels and push the disease back.
What are the key areas of unmet need in PAH from patient, healthcare, and societal perspectives?
So we want to focus on medicines that not only make people function better and live longer, but we want them to stop having morbid events. We want them to stop being hospitalized. And we also want to markedly improve quality of life. People want to not only live longer, but they want to enjoy their lives. And some of our medicines fall short of that. And so the unmet need is to really develop new therapeutics that can really work on the disease itself so that we can really markedly improve quality of life. And that's a very important piece for regulators also, because they want drugs that not only people make them function better and live longer, but feel better too.
How widely do you think current best practice is employed?
You know, it really varies from part of the globe to part of the globe. For example, in Europe, many patients who have pulmonary arterial hypertension are required to go to specialized centers to receive their care. And these centers obviously are people powered by the best experts in those areas. In other parts of the globe, there is very little access to medication, and that's a serious problem because this is a global disease. And then in areas like the United States, many of these patients often find themselves seeing community physicians, physicians that may not be as well versed in the disease as the experts. And unfortunately, many times in the expert centers, now we're seeing patients who are much down the line in this disease and are in serious shape. And it really has delayed the management of these patients. So again, educational opportunities are needed to inform our community physician when is the right time to send a patient to an expert. And that's where the evolution of risk calculators has really helped. Calculators like the REVEAL calculator, in which a community physician can make a very easy tabulation from readily available evidence and determine if that patient's on the road to dying. And that's when they need to send them to the specialist before that happens. And so these accurate depictions of scores are very, very important community management, such as we have in the United States.
When would tools like Reveal and Reveal Lite be utilized?
So once they are sure that a person has pulmonary arterial hypertension, that's when they would apply the Reveal calculator or the Reveal Lite calculator to tell them what this patient's risk is of dying. And if someone is in an intermediate or high risk of dying, these are really patients that should be referred to a specialty center to make sure they get the right combination of management and also have the opportunity to engage in clinical research protocols, which offer really new life-saving therapies.
Could current clinical assessment and management of PAH be improved? And how would this impact patients?
I think clinical management is improving, and it has improved with the institution of guidelines which really enforce the use of risk stratifications to really segregate patients into different areas of risk. And that is a really important development that has happened slowly over the last decade. But currently, even in our new guidelines, there's an emphasis to make sure that patients are risk stratified and to achieve a goal of achieving low risk. That means less than a 5% risk of dying in a year. And that's a lofty goal. And so risk tabulation is often done when someone is first diagnosed and frequently throughout the first course of their year, because the first year is really the most dangerous time for newly diagnosed patients with pulmonary arterial hypertension. So doing simple risk stratifications at key time points in that first year allows you to develop a trajectory in which way that patient is going, and so that your pace of aggressiveness with medication keeps up with that risk and allows you to bring that patient to a lower risk. So that is a really key management tool that we use very frequently now.
Do you foresee therapies that may have substantial impact on disease progression?
Disease progression is something that our regulators are looking at very closely now when they approve new therapies for this disease. They want disease-modifying agents, agents that directly attack the pathophysiology of this disease and drive it backwards or keep it at a standstill. And that's where all the new therapies that we are investigating now really fall into that category. We have drugs that work on the BMPR2 pathway, which is the key pathway in many patients who have heritable pulmonary hypertension. And even in most forms of pulmonary hypertension, there is an underexpression of this particular protein. And now we have drugs that act on that pathway directly. And so that's an example of the type of disease-modifying therapies that we are looking for in the future. Drugs like CS1, which actually work on epigenetic mechanisms, is a really novel way of treating this disease, working at the level of the DNA to alter the expression of genes is very forward-thinking. And I think it holds key promise for diseases like this, because the vascular remodeling, the unchecked growth of cells, the lack of death of other cells is really related to the expression of certain genes. And to be able to turn those genes on and off is very important.
What are disease-modifying therapies and why are they important?
Disease-modifying therapy means that these agents work directly on the pathophysiology of the disease. They are causing smooth muscle cells to stop growing unchecked. They are working on pre-programmed cell death. So in pulmonary hypertension, certain cells become immortal, certain cells turn over too quickly. And so we want drugs to reverse that back to normal. We want that cell regulation to be adaptive like it has been in normal people. And disease-modifying drugs work directly on these processes.
How do you see combination therapy developing in PAH? Would it be similar to the way therapies have evolved for heart failure?
In pulmonary hypertension, we always have to relearn the wheel from heart failure. And we understand in heart failure now we have multiple stages. Stage A, which are just risk factors for heart failure. Stage B, people who have structural disease but no symptoms. And then finally C and D, when people have symptoms or are at the end of life. And deploying a certain type of staging system in pulmonary hypertension really allows us to use combinations of therapy more effectively. In heart failure, again, we always use a four-pillar system: beta blockers, ACE, ARBs or ARNIs, mineralocorticoid antagonists, and SGLT2 inhibitors. And we've adapted that same sort of multi-tiered drug therapy in pulmonary hypertension, trying to make access of drugs that attack the disease from different pathological states. And I think one of the big things that's going to happen in the future now is now we have, a good armamentarium of drugs that we have experience using to bring people back in their risk and to try to stabilize them. And now the key thing is going to be adding a remodeling agent to that. So we've stabilized the patient with our older drugs, and now we added remodeling therapy that will push that disease back. So I think that's going to be the fascinating thing in the future is how we're going to deploy disease-modifying drugs like CS1 into this category of disease modification with our current therapeutics. And you can imagine that you might even use these drugs early in the course of the disease, even if someone is low risk, to really make the disease abate. Certainly in people with intermediate or low-high risk, these drugs will be very valuable in pushing people backwards onto this risk scale. And even for people that we have thought have had end-stage disease, well, this may be an opportunity to see if these drugs can really work in these very high-risk patients to make them live longer. So I think there's a lot of exciting information on combinational therapies that we'll have in the future with this new armamentarium of disease-modifying agents.
Where are we currently regarding the development of disease-modifying therapies for PAH?
I think we're well engaged in this process already. We actually have one drug that's likely to be coming to market very soon, sotatercept, which, as I mentioned earlier, works on the BMPR2 pathway, which is a critical pathway for the development and the progression of pulmonary hypertension. And we have about 6 other drugs that are being tested right now in various mechanisms of action that can be delivered subcutaneously or inhalationally, or even in a pill form. And so we have a lot playing right now, and it's a really exciting time to be in pulmonary hypertension because of the advent of these new disease-modifying agents.
Which is the most promising of these potentially disease-modifying therapies, and why?
The therapeutic that's coming to market is very exciting, which is sotatercept, which is a drug that actually works on one of the main pathophysiological pathways in pulmonary hypertension by regaining the expression of BMPR2, which is a critical protein that is needed for cell turnover in the lung. So I think that's a very promising drug. The results of the trials have been very promising, and I'm hopeful that we'll have that drug to use in the clinical environment shortly. We have other drugs that are looking at other growth factor antagonisms like PDGF, so a variety of tyrosine kinase inhibitors that are being inhaled, and several companies are bringing novel drugs to utilize that pathway to clinical trials. And then we have drugs that act on the serotonin system, which is another very important pathway for the development of pulmonary hypertension, and other drugs that are working really on the immune-related aspect of the disease. So we are really exploring all these novel pathways. And some of the most exciting ones, as I mentioned, are drugs like CS1, which are actually working on gene expression by inhibiting certain epigenetic factors that allow us to actually alter the expression of genes that may be critical in progressing diseases like pulmonary hypertension. So these novel areas of actually utilizing the power of the gene itself, I think, are very exciting.
What is the potential of histone deacetylase inhibitors, HDAC, for treating PAH, and where do they fit in the growing spectrum of novel therapies for PAH?
One of the most exciting areas of therapy, new therapy that we're exploring is in HDAC inhibition. And this is a really novel way to approach a disease. And I haven't seen HDAC inhibitors used very often in clinical practice, but they are growing in favor. And so what do these drugs do? So HDAC inhibitors really work on epigenetic mechanisms of disease progression. Epigenetics means that there are sequences in the folding of genes that is managed by certain proteins. And these proteins allow DNA to unfold and refold. And when DNA unfolds, we can affect the expression of the genes that unfolding allows us to see. And so HDAC inhibitors like CS1 can actually allow us to alter the expression of genes that may be very important in the propagation of pulmonary hypertension. And CS1 has very unique properties in that it not only affects the growth and turnover of cells, but very importantly affects thrombosis. And I remember, as a blood vessel gets smaller, the likelihood of blood clotting in that vessel is very high. And we know that in pulmonary hypertension, microthrombosis is a very key part of the disease. And we used to treat that in the old days with Coumadin, but we've kind of gotten away with that because we don't know how the relative importance of that drug is with all our new drugs. But having a drug that actually remodels the vessel and prevents thrombosis at the same time is very, very key for the management. So again, we're attacking a new area of the pathophysiology of the disease that can really help us remodel these vessels.
How important is the antithrombotic property of histone deacetylase inhibitors, HDAC, for the treatment of PAH?
Classically, we think the role of thrombosis is blood clots and blood clots that occlude things. And that is a very important mechanism in the microcirculation of the lung and in particular pulmonary arterial hypertension. But we also have to remember that the proteins that allow thrombosis to occur or that mitigate thrombosis also play a very key role in how cells turn over in the vasculature, particularly smooth muscle cells and fibroblasts, which form the outer casing of a blood vessel that can limit it from dilating. So in addition to mitigating clot formation, the regulation of these proteins that activate or inactivate thrombosis can really help us remodel the vessel directly.
Do you think right heart failure in PAH should be investigated with a focus on finding dedicated therapies?
One of the most important advancements that we really need to work for are developing therapeutics that not only mitigate the disease, but also help the right heart. Because improving the coupling between the right heart and the pulmonary vasculature, I think, is very key in determining prognosis. And drugs that can do both, I think, will be very well accepted in our armamentarium and actually could rise to first-line therapy. Because, as I mentioned, the right heart is the most important thing determining prognosis, and drugs that have dual actions on both the vasculature and the right heart will be very comely and very important.
For more episodes of our Insight series, please follow Cereno Scientific on LinkedIn or our YouTube channel.